Hello and welcome to the Fit Like a Girl podcast. My name is Jackie Lindahl. I am a mom of two, an avid coffee drinker, and a certified personal trainer. I have been in the fitness industry for nearly 10 years, and I help women get fit, strong, and lose weight without losing their damn minds. If you're looking for help on achieving your health, weight loss, and fitness goals without all the fitness industry confusion and BS, you have come to the right place. Welcome back to the Fit Like a Girl podcast. My name is Jackie. I am your host, and I'm really excited about this one today because I am joined by Dr. Karl Nadolsky, who is an endocrinologist and obesity medicine specialist. He also co-hosts the Docs Who Lift podcast with his brother and also an obesity medicine specialist, Dr. Spencer Nadolsky. So welcome. How are you?
Thank you. All right. Great to be here.
So I wanted to quickly touch on first your background, your specialties, why you chose those specialties, and what you do currently within your practices and teaching and things like that. So yeah, give us a little bit of background on you.
Yeah, so really the background goes, way back to when I was a little kid. My dad was a science teacher, biology teacher, football, wrestling coach. He played multiple sports. My mom was a sailor. We were really into science, into sports. And I was actually, I give a lot of credit to Hulk Hogan because my parents got me the Hulk Hogan workout set when I was like 1986 or so. So I was one of those guys with a little Hulkamaniac, little headband and stuff. And
Awesome.
I started going to work out with my dad at the high school when I was, in second, third grade. And that was like my thing. And it's always been my thing. And I've been pretty consistent with that. And then all the sports. And I wrestled at Michigan State. And so being kind of a, a science, biology nerd into sports, I definitely was interested at least in nutrition, exercise science. I mean, my undergrad degree was essentially kinesiology, kind of exercise science with a pre-med aspect to it. And then my mom's younger sister is a cardiologist. And when my brother and I were visiting her way back when I was going into my senior year at Michigan State, we were just talking about what we wanted to do. And she encouraged me to go to medical school because I was like, gosh, do I want to go to med school? People were talking about doing physician assistant stuff, whatever. And then later on, when we were talking to her about insulin, we're talking about nutrition and insulin and adipose tissue, and she was like, boy, you sure sound like you should do endocrinology. I'd never even heard that term before,
Okay.
And so then when I was in med school, we had our didactic month of each, subspecialty of medicine just to learn the real basic science. And endocrinology is a little bit funky for a lot of people because it's not as straightforward. You have to really get into these feedback loops. If you've ever heard of that, one hormone tells the other hormone, then, all this stuff goes on. For whatever reason, that stuff made perfect sense to me, whereas it was confusing to a lot of people. So that just was kind of a lucky sort of thing. And then, and I did the first part of my career in training in the Navy. And so I did internal medicine residency at Naval Medical Center, Portsmouth, basically like Norfolk's hospital base. And I had great mentors there, great resident friends. And, I certainly still had my endocrine obesity sort of interests, and I did well with those things. So I had a lot of encouragement to go down those routes. Although I will say my cardiologist mentors almost got me to do that route because there's a lot of overlap, right? Cardiometabolic health medicine. And right after I graduated internal medicine residency was the first year that all the different organizations came together and made the official American Board of Obesity Medicine certification. So I just happened to time out right with that. So I got certified in obesity medicine with that first wave of those guys. And then when I went to endocrine fellowship at Walter Reed Bethesda National Military Medical Center, it's basically the Army and Navy's combined fellowship program. I had connections to some really high-level mentors throughout the nation, including people in my own fellowship program. But that hooked me up with endocrine obesity specialists, and then I got involved in guideline writing and all sorts of stuff. And that's sort of ultimately my academic path. But then once it was time to decide if we were going to stay in or get out of the Navy, ultimately, yada, 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 decided to move home to Michigan, where I'm from. And there's a big, huge hospital system here that was looking for endocrinologists, wanted to do more obesity comprehensive stuff. So I joined them. And then now, just a year and change ago, I actually left that huge system and joined my local community hospital, literally the hospital where I was born once upon a time. I shouldn't really say when, I guess, but it's because I had Peter Pan issues. But then so we're starting their endocrine department. They never even had such a thing, which is why I probably wasn't with them in the first place. But now we're literally starting it from the ground up and wanting to build not just the endocrine department, but the obesity, diabetes, bigger picture, holistic sort of comprehensive program. Really emphasizing our dietitians and our want to put together a gym and teach people how to work out.
That's
and
awesome.
Try to help support our primary care colleagues and make our community hospital really well known and help our community really here. So.
That's awesome. So with, I guess, your goals of this new clinic that you're essentially starting from the ground up, you mentioned so many things that you're wanting to do. So currently within this clinic, or I guess what you did at your previous clinic as well, what kinds of things are you doing specifically with your patients, clients, and helping them with either their health goals, weight loss goals, whatever it might look like?
Well, so as a general endocrinologist, I get a lot of referrals for a lot of things. So endocrinology, we take care of diseases that range from hypothalamic pituitary disorders. Your pituitary is pretty famous as being kind of the master gland that communicates with a lot of the other famous actual organs, like your thyroid, your adrenal glands, sex glands. It makes growth hormone, prolactin, etc. Obviously, we deal with thyroid cancer, adrenal diseases of all varieties. We deal with bone disorders because there's a lot of hormones that basically deal with bone metabolism, so osteoporosis and other more rare bone diseases. And then certainly obesity and the metabolic diseases, so cardiometabolic disease. So all the complexities of obesity, but also the downstream complications like type 2 diabetes, fatty liver, atherosclerotic disease risk, so like heart attack, stroke risk type stuff, even kidney disease. And we're really also the primary caretakers for pretty much everyone with type 1 diabetes, which is the autoimmune disease that attacks the pancreas, essentially have to be on insulin replacement therapy with a variety of methods. And so, and there are a bunch of other ones. Some, we deal with a lot of what we call zebras, so like rare things.
Yeah.
So we're the ones that see some of those. So.
That's cool. So a very wide variety of people and things that you're dealing with. Obviously, like you mentioned with endocrinology, it's a whole very complex system. So it's not just dealing with hypothyroidism or diabetes. There's a multitude of things.
All sorts of stuff. Yeah. It keeps it fun because the primary issue in the world is obesity and the downstream complications. So we do a lot of that. We do a lot of diabetes, but I enjoy still being somewhat well-rounded within endocrinology, not internal medicine generally anymore, but I still like doing all the things for endocrine stuff.
Yeah, absolutely. So with being an obesity medicine specialist, it's not a specialty that I actually heard of until you and Spencer talked about it. So tell me a little bit about that specialty. What drew you to it? What are the intricacies of it and things like that?
Yeah, so back kind of like I said, when I was in college and stuff, we were all about sports nutrition performance. And kind of as I went through medical school, and like I said, my aunt said, oh, endocrine and all that. I was always thinking, well, what could I do to help people that is in line with my interests? So nutrition, exercise, weight, energy balance, adipose tissue, the health issues that come from that. And that's really what kind of drove me to that interest itself. So I already wanted to help people with their weight. And as I went through training, I got to learn so much more about why, how obesity itself is really a very complicated disease process. Because if you would have asked us 20 years ago, I would have said, oh, I can get everyone to be, muscular and ripped like me, just with good nutrition and exercise, no drugs or anything like that. Turns out I was very wrong. I had a certain genetic background, like everyone has different genetics. And like I said, I literally was working out with Hulk Hogan's workout set at the age of 6, and I haven't stopped ever since. And so I have a different physiology than other people. And so it really became interesting for me to learn the disease pathology of not only obesity, but then how obesity causes harm, like specifically insulin resistance and type 2 diabetes, because that's another thing. Like in med school, I think we all thought, oh, if you're drinking sugar or eating sugar all the time, you're making your insulin go up and you can't deal with it. And we thought that's what led to insulin resistance. That's what a lot of like the keto zealots think still, or at least that's what they say. That was wrong. They're wrong, basically. I mean, from what we know. And so then it was really interesting for me to learn more of the real adipose pathophysiology during that time. And it took a lot of extra study. I had, interestingly, one mentor in internal medicine. He was actually a pulmonologist, critical care doctor from Ireland. This like kind of like genius guy that like knew a lot of stuff. And he kind of started doing a lot of literature review into obesity because he was dealing with so many people who were dying in the ICU because of their obesity, and all that stuff. So he actually kind of guided me because he knew I had that interest. So, so I learned a little bit from him, or at least how to read and learn stuff, and then certainly doing the extra work it took to do obesity medicine. And obesity medicine, just in basic terms, is just it's an effort to train physicians or other clinicians to have a little bit better understanding of the disease of obesity and how we can help people treat it in all different ways, what the goals are, but also the complications of obesity rather than treating the downstream complications. So really getting to the root issue that we just didn't know. I mean, it's a relatively new science. I think everyone once upon a time just thought, oh, diet, exercise, easy day. I mean, that's still partly true, but there's just so much more complexity to it that we didn't know not that long ago.
Yeah, no, that's very, very true. And it's something that I think you talk about a lot in your social media and things like that, is that obesity is so much more complex than we can even begin to understand. And there's so many underlying things that so many people don't understand, because you're right. Most of the general population just thinks obese people are lazy. You eat too much. You don't exercise enough, not understanding there's so much more to it, and that it is a disease. And it's even controversial to say it's a disease, because I see in your comment section.
it shouldn't be. I don't know why people like it to be that way, but for whatever reason, it invokes emotion. And sometimes for better, sometimes for worse, though.
Yeah, it really does. And not only that, like the weight stigmas and things like that we have, I mean, just in society against obese people, and even within the medical community, stigmas, like, with weight and things like that with obese people. And it's really important that you guys talk about this so much to help break down these barriers, and so that people can get the help that they need if they need it.
Yeah. And so, kind of to that point, that's another, we talk about how people, they have their disease process as opposed to it describing them. So people used to, say people were diabetic. I still have patients that say, yeah, I'm diabetic. So, well, you have diabetes, you have this, and there's still a little bit of a sensitivity about the term obesity, even as a disease. So I often don't even say, I don't even say you have obesity as opposed to you are obese. But, I just say that I talk about the complicated pathophysiology of their weight and what harm it can cause.
Yeah.
Everyone's different, though. I think some people, they almost want like the derogatory terms for some reason, whereas others, I think it's not helpful. It's interesting. I don't, you can't read everyone's mind, but anyways, that's just a little nugget.
Yeah, it's definitely dependent, I think, on the person and how they view it and things like that. That makes sense. Yeah. So some things that I wanted to chat about is and the reason why I wanted you to come on specifically was because I, of course, like hormones and weight loss and hormones affecting weight loss and all that kind of stuff has been such a big talk on the old social media lately. And as a trainer, I'm getting tons of questions about things like cortisol and PCOS, endometriosis, menopause, postmenopause, all of these things that I'm like, I'm not a hormone specialist, but I got a guy. So I wanted to dive into some of these topics and get your expert opinion and what the science is actually showing, and kind of break these things down in what's the truth out there, because there's so many, as you like to say, quacks out there on the internet.
And that ranges from doctors to whomever,
Exactly.
It's unfortunately, I wish it weren't, but
It is. And that's what the hard thing about it is when you have a specialist over here saying this and another specialist saying that and a
Hmm.
doctor of, whatever medicine saying
Yeah,
this, it makes it so hard. So let's dive into a few different hormonal issues and disorders that
sounds
commonly
good.
affect, especially women, like, for example, PCOS and
Yeah.
endometriosis. So, if we could chat a little bit about your knowledge of it, how these things can affect weight loss, and also that so many women who struggle with these issues feel as though it's hopeless. It's hopeless. I feel like I'm
Yeah.
forever going to gain weight. I can never lose the weight. What makes it so hard?
Well, so pretty much for anybody who's struggling with the weight, it really comes down to, like we said, there's that foundation of genetics. Some people have a genetic milieu that is almost protective. Maybe that person would not have done well a million years ago in our evolutionary terms, but evolutionarily, we developed a variety of genetic predispositions to essentially hold on to adipose tissue. Now, there are some very severe genetic syndromes where the axis that we're going to talk about like doesn't work and they cannot stop eating no matter what, and
Mm,
it's relatively rare stuff, for most people it's a complicated genetic predisposition, and
okay.
it kind of sets people up for having almost what some describe as like a broken thermostat in their house. It's
Okay.
trying to push them towards an amount of adipose tissue that maybe isn't so healthy.
Mhm.
And people talk about that being a set point or settling point. It doesn't matter. We don't have to get into those details, but it's working against people. It's that biology
Mhm.
working against people. We have hormones that are supposed to be communicating with that area in the hypothalamus. That is our, kind of our control center, that come from our adipose tissue. People are maybe now familiar with leptin. It's
Mhm.
supposed to work for us. It should tell your brain, hey, we got enough adipose tissue, we got enough storage, and maybe improve appetite, improve satiety, etc. But then there becomes a resistant state to that for a
Mhm.
whole variety of reasons,
Right.
environmental triggers and stuff like that. We have hormones that come from our intestines that are working for or against us. That's where the GLP, the GIP hormones that we have for weight reduction and diabetes come from.
Yeah.
Our small intestine. We have a hunger hormone called ghrelin from the fundus of our stomach. We actually just talked about that on a gastric gastroplasty sleeve discussion we just had, literally like a half an
Yeah.
hour. And then all the different hormones you hear about in your brain that are controlling the reward system. You hear
Mhm.
about dopamine, serotonin, norepinephrine, all these different things that work up in that different areas of the brain, but the brain stem and also the hypothalamus, where we have a couple centers. I don't think we need to get into the necessarily the terms of them for people, but we basically have our hungry part and our not so hungry part, and then they
Right.
also go to second order neurons up above and modulate our appetite, our energy intake, and to some degree our metabolism too.
Mhm.
And then I basically tell people, and then life throws all sorts of monkey wrenches into that, right?
Of
And
course.
it's so everyone's different. People have different medical issues that they deal with. They have different diet and exercise that they grow up with. So then they have different body compositions when they grow up. Maybe they were exposed to different viruses. So
Yeah.
a researcher who talks about obesities as if like all the different types of obesity. And I'm
Oh,
not talking
okay.
about the complications that I usually talk about, but he's talking about the different causes of these
Right.
dysfunctional energy balance issues. And so there are data that there are different viruses that have triggered dysfunction. We know
Interesting.
different people have, different amounts or effects of their brown adipose tissue. That's kind of our metabolically active adipose tissue that has
Mhm.
to do with our basal metabolic rate. People have thyroid diseases, right?
Mhm. Mhm.
Adrenal diseases are much more rare, and none
Mhm.
of those things actually cause significant obesity. So a lot of the hormones that people think cause obesity are actually not really causing obesity. It's
Right.
actually having to do with all sorts of different hormones, but not necessarily tumors or anything like that we
Yeah.
look for with other hormone disorders. It's just a complicated setup of a dysfunctional orchestra of all these different adipose tissue weight regulating hormones,
Mhm.
and our diet, our exercise, our sleep, our stress, and then other medical conditions and life. People
Yeah.
get pregnant, they have babies, they
Mhm.
get married, they get divorced, they eat out more, they don't have enough money, they get sick, they get different medications, they go through menopause, all these different things, and it adversely sometimes adversely, sometimes people do fine.
Yeah. Yeah,
Everyone's different.
absolutely. Well, yeah, everybody's reaction to different stressors in life is different. That's how some people, when they are stressed, they don't eat and they'll lose weight. And other people, when they're stressed, they turn to food and that makes them gain weight. But it's interesting how, like you just really described there, exactly how complex all of these things are and how complex obesity is. And that different receptors in the brain affect different
Yeah.
people and your hunger levels, your satiety levels, and all that kind of stuff. And that it's not just as simple as people think it is.
Yeah, wish it were. And I also tell them that all those things then, even though the front part of your brain knows what to do, you try to eat vegetables and meat all the time and have like this perfect diet. If
Mhm,
we're in this environment, this obesogenic environment we call it, it's like you can't help it. So if you're
mhm,
exposed to the hyper palatable, hypercaloric, yummy foods all the time, if you kind of have to rely on restaurant food that
mhm.
overwhelms us, the ultra processed food environment we have that overwhelms that system. It's just a lot of different complicating things.
Yeah.
Yes, it ultimately does come down to working on nutrition and exercise and all that stuff, but a lot of complicating factors on either side of that equation.
Well, there is, and then there's things like, I know one other thing that affects things is like food noise. So somebody
Yeah.
who's trying to
And
lose
that's
weight
those hormones
and
in the brain, right? So that
yeah.
gets into some of the GLP stuff, why those medications work so well. They're working up in
Mhm,
that area of the hypothalamus, reducing satiety, the brain stem, some of that dopamine reward system stuff,
mhm.
and now they don't have that noise. And
Yeah.
I'll tell you, we have people all the time, ever since we started doing this years ago when I was in training, who come back and say, "Oh, this is what it's like to feel normal when they're getting the
Oh,
right therapy." I mean, that is
yes.
fascinating
Yes.
to
Yes.
hear them
And
say that.
yeah, and I mean, I didn't exactly plan on talking about it, but since I kind of actually do want to bring it up is the popularity of the old Ozempic, and I'm sure you get
Mhm,
a million and one questions about this all the time, but
mhm.
how it can be helpful for people who struggle with all of these kinds of things by, slowing digestion, taking away the food noise
Yeah.
in the brain. Can you talk a little bit about how these medications even work? Because I don't know if a lot of people even really understand how they work and how they can help people.
Yeah. So we'll talk about just the GLP-1 hormone first. So that comes from our small intestine, and it goes up to the brain, the hypothalamus, and some of the brainstem receptors, and that's where it really helps with reducing appetite, reducing the food noise, etc. They've been approved, which means they've been studied a lot longer, by the way. But
Yeah.
I was using these medications as a med student a while
Mhm.
ago. So
Yeah.
the first one was approved, I think 2005 or so. And they're approved for type 2 diabetes because they also work on the pancreas. So that's the incretin effect. So when you ingest essentially glucose, when you digest things, it triggers the release of these hormones in the small intestine. They go to the pancreas to help the pancreas start churning out some insulin early on. And
Mhm.
then they slow the stomach down, which is helpful. They work on a different hormone from taking essentially the sugar out of the liver. So it works
Mhm.
on that aspect because that becomes unopposed in diabetes as that obesity drives type 2 diabetes. And then it works up in the area of the brain. So people have been using these for a long time now. I can't believe it's been almost 20 years we've been using
Yeah.
these medications. And they were already game changers, even though they weren't as good as what we have now. So we
Yeah.
had exenatide, which was from the Gila monster first, the salivary glands of the Gila monster, they figured out. And this was in conjunction with studying like gastric bypass and stuff too, because they were noticing,
Okay.
oh, wow, when we get basically those our body's natural hormones were going way up after gastric bypass. And,
Mhm.
and they're, the researchers were figuring this out and putting it together. And then, but that was a twice a day shot initially, the
Okay.
exenatide, great for type 2 diabetes. And then when I was a resident, then liraglutide, which is known as Victoza, was approved as a once a day. It was even better, really good, pretty good weight reduction, good glycemic sugar control. It ultimately was the first one to show a reduction in cardiovascular death, like heart attacks, strokes,
Oh,
and
okay.
death for people with type 2 diabetes and established heart disease. So that was kind of hopeful, but certainly nice to see. And then it was approved at a higher dose for obesity, for weight reduction.
Okay.
It didn't get as much traction as the weekly ones that we now have that
Mhm.
we're going to talk
Yeah.
about because it just wasn't as dramatic, but a really good medication that we were using for a long time. And then we started getting weekly versions of these approved. There's one called dulaglutide or Trulicity for type 2 diabetes. It has cardiovascular reduction data in it. And then there was the semaglutide, which is kind of like Victoza, same company, but weekly. That's Ozempic. And then, and so, that was approved several years ago before it like blew up in the media. I mean, we were using it for obesity, type 2 diabetes, and even some off-label because we had all the studies for the weight loss and the diabetes prevention and people who didn't quite have diabetes yet.
Right.
And then it was approved for weight reduction at a little bit higher dose called Wegovy. And that's kind of when, and for whatever reason, then everyone just started calling all of them Ozempic. So for better or worse, I don't know why that's the case, why that happened, but I think people started figuring stuff out. And then, of course, we ended up getting the GLP-1 GIP receptor agonist molecule called tirzepatide, which was approved for type 2 diabetes as Mounjaro, and then it was recently approved for obesity as Zepbound. Same exact stuff. But that's kind of how they work. I mean, they help the pancreas work better. They slow down the stomach. They work up in the hypothalamus and brainstem to improve satiety, reduce appetite, reduce the food noise. Tirzepatide may have a hint of metabolism benefit in animal models, but hard to say that in humans so far. Doesn't really matter. Really good medications for those who truly need it, by the way.
Yes.
Those with real obesity, especially complications of obesity like prediabetes, fatty liver, type 2 diabetes, heart disease, sleep apnea stuff.
Yes, and that's super important to remember because I think, in the media, everybody right now, it's like anybody who the image that people get in their heads is that it's for anybody who wants to lose 10 pounds, which obviously isn't true. Like these medications
not appropriate.
Are for those who truly need it. And, people, and it's also the risk versus reward because people will also say, well, what about the side effects? And it's like, well, any medication has side effects.
They are drugs, and by the way, I'll tell you that any supplement that anybody sees out there, if it does anything physiologically, it is a drug. It just happens to be, the way it's studied and approved as a supplement. But I mean, these medications, they are very, very safe. So if they were really, really cheap, I think we'd have a little bit lower threshold to say, well, okay, a lot of people could use them maybe because they do have a lot of health benefits, but there's still risks. I mean, they a lot of people get nausea and vomiting, some other GI stuff like constipation, diarrhea. There's a hint of an increased real risk of like gallbladder disease for people who still have their gallbladder. There was some concern of like pancreatic disease that really hasn't panned out in all the huge trials so far, but there's still a little bit of that, at least concern in the back of people's mind. Certainly if you cause someone to have a gallstone and they get gallstone pancreatitis, then that's a problem. Although there are causes of pancreatitis that can be maybe reduced with this, like high triglycerides or even, alcohol is a common cause of pancreatitis. And these seem to work just like, kind of like food addiction, alcohol addiction, smoking addiction, similar type hormones in the brain or receptors in the brain that kind of cause that feeling of addiction. People can debate that term, doesn't matter, but people are reducing their alcohol intake too. So, there's some of that benefit. And not a lot of other real risk, but it's not zero. So if you don't have a lot of benefit because you don't have true obesity and more severe disease of obesity, it's still a drug. So like I wouldn't take it just to get like lose an extra pound of fat. You know what I mean? Like that doesn't make any sense. So
yes, exactly. And there's the risk versus reward for people who truly need it. The risk of, the potential complications of obesity and things like that versus the risk of the medication. And that's up to the medical provider and the person to decide.
Yeah. So the more risk, the more severe disease they have, the more benefit they're going to get compared to whatever little risk of the medicine. That's how we do that's how we should do everything in medicine.
Yeah.
Technically. So.
In theory. Yeah. So I wanted to dive into, like a few more other things. One other thing that you had brought up earlier was insulin resistance. So this isn't something that is, I think it is talked about a little bit, but I think it's talked about by the wrong people in the wrong context. So can we dive into what is insulin resistance, how it can happen, and why it can affect things like weight loss or weight gain, and things like that?
Yeah, so the basics of insulin resistance means, your pancreas makes insulin in response to ingestion of carbohydrate essentially, but also a little bit of protein and fat to get those nutrients into cells. And so if we talk about obesity, everyone has a different way they store their adipose tissue, right? So we have our healthy peripheral cells that people may not like, but around the kind of that pear shaped, right? The button thighs, the kind of the peripheral adipose cells. Now, adipose tissue is a metabolic organ, but that these are like healthy storage depots.
Yep.
But there seems to be this individual threshold at which those cells sort of say, all right, we're done storing it. And that's the beginnings of insulin resistance. So then the fatty acids in the bloodstream go up. You're starting to store more in the visceral obesity. So that's the abdominal cavity you hear about. Then there's what we call ectopic triglyceride or ectopic fat. That means it's not where it's supposed to be. So now it's in the liver, it's in the muscle cells. That's all insulin resistance. And then it's also getting into the pancreas. And the pancreas is having to deal with that insulin resistance. So the insulin is going up to try to keep the sugar levels in the bloodstream normal, because we should have fasting blood glucose that are below 100 milligrams per deciliter, and we really shouldn't go up more than 140 when we eat. There's a little bit of variance to that, and I'm sure we can all make ourselves go up a little bit higher than that. But basically, when the pancreas is having to work harder, crank up insulin to try to go against those demands, that's insulin resistance. And there are some, technical research things that, we can measure insulin and sugar and calculate insulin resistance if they don't actually have prediabetes. But once the pancreas can't meet those demands and the blood sugar starts to go above certain thresholds, we have criteria to diagnose prediabetes. So impaired fasting glucose, if the glucose is above 100, impaired glucose tolerance, if we do a 2-hour tolerance test where you have to drink a syrup and see how high your sugar goes. If that goes up over, if it's above 140, that's impaired glucose tolerance. But and then we have the hemoglobin A1C, which tests an average blood sugar on our red blood cells for 3 months, and between 5.7 and 6.4 is prediabetes for that. So there are different ways for different people to get that diagnosed. Yeah. But then once the pancreas really, really can't keep up with it, and the insulin actually, now we have a relative insulin deficiency. And this is like the common denominator of all the complications or all the factors that go into this. Then the blood sugar goes up more. It gets into the criteria for type 2 diabetes, because that's where we suddenly have this dramatic increase in all the complications of high blood sugar chronically. The leading cause of blindness, kidney disease, nerve disease, and then the whole thing is what drives, cardiometabolic disease risk of, the blood pressure, the lipids, and the glycemia, all leading to heart disease, et cetera. Inflammation that you hear about all the time. That's all driving that stuff.
Right. Yeah. So somebody who is dealing with insulin resistance, what are, I guess, some of the ways can they manage it? Is it something that can be resolved? Because correct me if I'm wrong, insulin resistance can be a precursor to prediabetes and then leading into type 2
so
diabetes.
it is the first part of that spectrum we were just talking about. Now, there can be some very severe insulin resistant disease states. So there's something called lipodystrophy. So this is a type of variety of diseases where those healthy fat cells, they don't work at all in different parts of the body. And that is a very severely insulin resistant state, and it drives all the adipose tissue into the liver and the visceral area, and causes really early on, type 2 diabetes, because the body can't deal with that insulin resistance, right? But, so that's just an example. That's like almost an extreme version of what happens in type 2 diabetes. See, some people can have a BMI of 100 but not have any insulin resistance or type 2 diabetes. But there are very thin people who just don't have very genetically behaving, peripheral adipose tissue, and they have abdominal obesity, and they have the worst type 2 diabetes and atherosclerotic disease, right? But the bottom line treatment for insulin resistance and prediabetes through type 2 diabetes, that spectrum of sugar disease, is technically weight reduction. So, and it almost doesn't matter what weight you are if it's truly kind of that adipose driving disease, as opposed to, say, like these diseases of lipodystrophy that I mentioned. But and so, like, some of the best evidence we have come from this guy named Roy Taylor in the UK, and basically he's the one that did all the huge studies with doing meal replacement shakes and vegetables. That's it. Easier said than done, but the best evidence we have for weight reduction, diabetes remission, getting rid of insulin resistance are from those studies, because they're so dramatically creating that energy deficit. But it doesn't have to be that. what we should do is use all the different studies for nutrition and try to personalize it, right? So we can cut carbs, we can cut fat, we can do meal replacement shakes, we can do intermittent fasting, time restricted feeding, we can be a little bit more plant-based. Probably not so much carnivore. I don't know why people are doing carnivore, because I feel like we should still at least get some vegetables. I mean, if you want to eat all green vegetables and some low-fat protein, that's great, fine.
Yeah,
but the whole like not eating any plants is a little, that's even more weird to me than being like a complete vegan. No offense to anybody doing vegan carnivore, but those two polar opposites don't make that much sense to me. But
I don't disagree.
Some dietary patterns, like the Mediterranean pattern. So when we get fat from nuts and seeds and olives and omega-3 fish fats compared to, say, saturated fats, most saturated fats anyways, that's better for insulin resistance, diabetes, and heart disease stuff. So all these things can be taken together, but it ultimately is treating the underlying obesity that's driving the insulin resistance that is the key. And again, back to what we started talking about earlier, it's easier said than done. So that's why sometimes we need medicines or surgeries or, just multidisciplinary efforts for some people.
Yeah, exactly. That makes sense. And so somebody who is insulin resistant, are they more sensitive to carbohydrates? Do they have to do like a lower carbohydrate diet or anything like that? Or what is
not necessarily. So certainly, when we have people with type 2 diabetes who are really struggling with high sugars, we absolutely do look for any of the unnecessary empty calorie carbs and sugars we can get rid of. Absolutely. Because that's going to help with their sugar control, right? If we cut their carbs down first. But people with obesity and type 2 diabetes, insulin resistance, anywhere on that spectrum, as long as they can lose weight, lose that adipose tissue, it doesn't have to be low carb per se. In the short term, the low carb absolutely is better for their blood sugars, but we call that a glucocentric approach. They're only worrying about blood sugars when there's a lot more to the disease process and a lot more harm. So certainly having a plant forward, it could be a little bit higher carb diet as long as they're ultimately resulting in the weight reduction and the health benefits. That's fine, even though they might have some higher glucose spikes. That's kind of why we don't tell people with just real early insulin resistance to use a CGM, even though a lot of people out there promote that, the continuous glucose monitors, because if you go on a really low carb diet, you can make your sugar flat, but that doesn't necessarily make you healthier,
right?
And some what we call glycemic excursions, sugar spikes, some of it's normal, and if you're working towards the end of getting yourself healthier, having some in the short term, that's not that big of a deal. So no, you don't have to be low carb. Certainly, I would argue that if we could make things perfect, probably a relatively low carb, high plant, high fiber diet that is a more Mediterranean based pattern, minimally processed foods, all that stuff is going to help people, generally speaking, but it doesn't have to be one extreme or the other, really.
Yeah, that makes sense. That definitely makes sense. And so when we're also talking about other endocrine disorders such as like PCOS, endometriosis, and those kinds of things, I know one common question that came up with quite a few of my clients who deal with these types of issues is that feeling of like helplessness and frustration because their body, like you'd mentioned before, their body and all of these different systems are kind of working against them. And there's so many quacks online talking about how if a woman has PCOS or endometriosis, we need to balance the hormones, whatever the fuck that means.
No, that's so that's not exactly true. However, PCOS is the most common endocrine disorder in females, especially females of reproductive age.
Right.
And so it really is. There's another genetic foundation to it, right? Not everyone gets PCOS. But it's essentially a female-specific component of kind of insulin-resistant metabolic syndrome type stuff. And so we don't know everything. And I thought they were going to change the name internationally to something called metabolic reproductive syndrome, because polycystic ovaries don't even have to be included to have the diagnosis. But it is a sort of insulin resistant state, or at least a high risk of insulin resistance. And you have a higher risk of developing diabetes later on. There's a little bit higher cardiovascular risk. And so I like to explain it in real simple terms. This is not exactly scientifically sound, but like it's like as if the ovaries are insulin resistant and they're being stimulated more by like our pituitary hormones. So they are cranking out a little bit more testosterone than they should be. So there is a
Okay.
little bit of quote unquote imbalance, even though that is absolutely a red flag of quackery when they start saying balance your
Right?
hormones. But in PCOS, it is a kind of a little bit true. That's why they have this, they do have an imbalance and a little bit, and they are getting adverse effects from it. So they're having irregular menstrual cycles. So that's not good for the endometrial lining, first of all. Get hair growth where you don't want it, acne where you don't want it. And then ultimately there's that risk of insulin resistance, prediabetes, diabetes down the road. And so we want to treat them mostly with these dietary efforts and weight reduction. And again, they are often people who require medication.
Right.
It's not PCOS per se that is the problem. It's still their genetics and the adipose tissue and how the adipose tissue and the adverse effects of that stuff are causing problems for them.
Yeah, for sure. That makes sense. And I know, like, like you said, it's so unbelievably common, and I feel like it's also being like more diagnosed. But it does, from my understanding, it does kind of sound like PCOS is an umbrella term for multiple different things that could be going on.
Kind of. Well, and there are a lot of things, especially in endocrine, that we have to rule out before we call anybody PCOS. So, because there are
Yeah.
mimicking disorders, so we have to rule out prolactin secreting tumors because that can mimic it. We have to rule out thyroid disease because that can mimic it. There's an adrenal disorder that's a genetic thing called congenital adrenal hyperplasia, which we don't have to get into that, but that just has to do with a little enzyme defect in the adrenal glands. But it's not totally uncommon, so we have to screen for that, make sure it's not those things before we diagnose somebody who has irregular menstrual cycles, maybe some acne, some hirsutism, maybe some polycystic ovaries, who otherwise have criteria for the PCOS, and then treat accordingly.
Right. Yes. Okay. And this is, I guess, like part of when people struggle with PCOS and they're specifically struggling with weight loss, that getting the help of, and I mean, it's easier said than done, getting more additional help from specialists such as yourself to potentially get medications or, do whatever needs to be done. But then it can help the weight loss because I know, like I said, so many people get frustrated with weight loss. They feel like their body is fighting against them, which in a way it
And it
is. And I
is.
get that.
Absolutely it is. Yeah.
So, what are some things out that can be within a person's control with this, with these types of issues? What kinds of things can be within a person's control that they can be more mindful of to maybe achieve a healthier body fat level or a healthier body weight?
Well, and so that comes back to the basics. So all those nutrition things we just talked about, minimally processed refined foods, don't drink your sugars. You can enjoy some diet soda. That's probably not a problem. Minimizing restaurant food. And then, looking, can we cut some carbs? Can we cut some fat? Make sure we're getting our protein okay. Use meal replacement shakes here and there. Some intermittent fasting, time restricted feeding, all those different things we can do to create an energy deficit. That will help the PCOS. Maybe a little bit of the pattern, quality stuff like Mediterranean diet might be a little bit beneficial for PCOS. Certainly all different versions of exercise. Exercise, by the way, doesn't help a lot of people with obesity lose a lot of weight. On average, it's only like a couple % weight loss in all the big trials. But more importantly than that, we know it treats the adverse effects of obesity. So in PCOS, it's just good for you. It's good for your insulin resistant risks. It's good for your metabolic health, all that stuff. So aerobic activity, resistance training. Of course, I'm a shield for high volume, resistance training. I think that's perhaps should be a priority for people. So those are the things. But yeah, it is easier said than done. They might need to be on birth control pills. We might need to use some of our diabetes or weight reducing medications to help them with that aspect of it. We work with our reproductive endocrine colleagues to help with fertility, because that's another thing. Young reproductive age males, we're talking about family planning a lot. We want to make sure that they can have healthy fertility and healthy babies and good family lives. So
Yeah, absolutely. That makes sense. So if we're kind of going from family, or I guess like reproductive age, to the opposite end of the spectrum, where we have women going through perimenopause, menopause, postmenopause, this is something that also gets thrown at me so much. I mean, I know the research doesn't necessarily show it, but so many women who are approaching this menopausal age are convinced that their metabolism is slowing, they're gaining weight, they're having all of these side effects of menopause, which do not sound like a walk in the park.
No.
What are some common misconceptions that you see regarding menopause and women going through this stage of life in regards to their health and or weight loss, because that's always a big common question, is how do I lose weight in menopause? I feel like I can't lose weight in menopause.
Yeah.
It's over for me. I'm over the hill.
So it's not over, and we certainly see this a lot for a variety of different reasons. I usually have to end up digging into this with females. It's interesting. They don't come to me say, "Oh my God, I'm going through menopause. Please help me." I have a feeling they might do that with their OBGYN docs more than me. With me,
Okay.
they're coming in for maybe the weight struggles, or they were being asked to look into other hormone issues because of fatigue or something, right?
Hmm.
And so the basic truth of it, based upon all the studies, is that there definitely does tend to be a little bit of weight gain through the menopausal transition on average. But again, everyone's different.
Yeah.
It's not really causing dramatic weight gain, and it's not really causing metabolism to go down. Metabolism does start to reduce a little bit later on in life, just kind of on average.
Hmm.
But there's also, maybe more importantly, a little bit of that adipose distribution change, so
Hmm.
kind of the pear versus the apple that I was talking about, how our healthy fat cells deal with it and where it ends up getting stored. So
Yeah.
untreated menopause, that excess weight, if, as again, we're still battling our own biology, right? And
Yeah.
life changes. People are just different. Our energy balance changes and we're gaining weight. Now it can start being more adverse cardiometabolically. So I will say that real subtle data suggests that people who use menopausal hormone therapy compared to those who don't seem to gain less weight. It's not
Mm,
a
okay.
obesity treatment by any means of the imagination.
Hmm.
And then there does tend to be, especially if used early on, less of an adverse adipose distribution, and thus maybe some more metabolic health things. Now, the reality of it is, absolutely, people are having hot flashes and not sleeping well. They don't feel
Yeah.
well. They don't feel like doing anything. They're not exercising. They're not out working out. They don't want to eat well. So if you're miserable, that's talk about a vicious cycle. So I will say
Yeah.
that when we do this a lot, and we say, well, geez, you're going through menopause. It's pretty obvious. You don't
Yeah.
need to do hormone testing, by the way, like so many people do. It's a very
Oh,
clinical
okay.
diagnosis. It's very obvious.
Yeah.
It's not rocket science. It's endocrinology, I guess. But and so we decide, okay, pros, cons, risk, benefits. Menopausal hormone therapy. I mean, really simple. There are a lot of people out there like trying to complicate this too, but the studies are pretty clear. I mean, it's pretty beneficial for people, and
Yeah.
especially symptomatically. Then they do better. Then they feel better. Now they're sleeping better. Sleep's like the unsung hero for metabolic health, by the way.
Yeah.
And then they feel like they can eat better. So a lot of
Yes.
times they do better with their weight loss efforts, their nutrition, exercise. There was a small observational study recently where they even said people who are getting, like say Ozempic or Wegovy or whatever, were doing better in the menopausal period when they were getting female menopausal hormone therapy. Now, it
That
was
makes
a
sense.
relatively small number of people. It wasn't a randomized controlled trial, but it
Okay.
does make sense.
Yeah.
And so I think it is important. I mean, and and there are a lot of other complicating factors going through menopause. But boy, if you feel better, we know it's good for that
Mhm.
stuff. We know it's good for your bones. If you start earlier on, compared to like waiting until you're in your mid 60s, 15 years after menopause, and you develop heart
Yeah.
disease or something, then you tend to get a little bit trend in those benefits rather than the
Hmm.
risks. So
Yeah.
that's good. And it doesn't cause breast cancer. If people have breast cancer or a strong family history, we don't do it because we don't want to give the fuel to it.
Yeah.
I mean, there's some nuance, but even then, it's still a risk benefit ratio kind of thing that they have to discuss. So yeah.
Yeah. Yeah, that makes sense. And one thing that you mentioned was interesting was even as you change in life, your hormone changes and all that kind of stuff, it can change where you would store that extra
Yeah,
body fat. So it
that
explains
matters.
why some women feel like, oh, I never had a belly my whole life. And now all of a
Yeah,
sudden I went through menopause. I'm not
yeah,
sleeping well. I'm not eating well. My activity
yeah,
levels aren't what they were. And now I'm storing, now my pants don't
yeah,
fit. And
yeah.
they're like, well, it's a menopause belly. And it's like, well,
Right. Kinda,
unfortunately,
but
yeah.
not exactly. I mean, there's just so much more
Yeah.
to it. Yeah, yeah, yeah. And
Yeah.
again, that's why we have to, the quacks hijack the term holistic, but real medical doctors have always been taught we treat the whole person. That is talk about a
Yes.
holistic area. That's why I like to use that term so much, because we have to think
Yeah.
about the whole picture.
Yeah, yeah, that's fair. And using the term holistic in the way that it should be used, not
Yeah.
everybody and their dog talking about how they're a holistic functional personal
Right.
trainer.
Yeah. That's quackery for sure.
That's a quack. Let's chat about cortisol because
Yeah.
that is the other one that I hear about so much about cortisol. Do I need to change my cortisol? How does it affect weight loss? What does cortisol even do? Because it does multifunctions within the
Yeah.
body. And yeah, how it affects weight gain and or weight loss.
So cortisol is extremely important. I describe it to patients as our stress hormone that comes from one of the layers of our adrenal cortex, so the outside part of our adrenal glands. The inside makes what people might think of as adrenaline, the catecholamines that get things, really up and running kind of thing. But cortisol is our stress hormone, and it is mostly technically catabolic, meaning it breaks things down, but it drives certainly metabolic changes too. So when people have and our pituitary essentially has what we can call cortisol stimulating hormone. It's called adrenocorticotropic hormone, but it
Hmm.
goes to the adrenal gland, tells the adrenal gland to do its thing, and it's making cortisol in response to day, night, food, stressors, illnesses, stuff like that. We need it to go up. It in high amounts, it breaks down muscle. It's bad. It breaks down bone. It
Okay.
distributes adipose tissue exactly where we don't want it if there's too much of it,
Okay.
from our healthy fat cells into our visceral abdominal cavity. Too much of it will drive hyperglycemia, insulin resistance, diabetes, that kind of thing. And the most common cause of too much cortisol, like Cushing's syndrome, that's what we
Hmm.
call that,
Yeah.
is medications. So people who
Oh,
have to use prednisone or other
right.
drugs for inflammatory disorders, they end up needing to be on too much of it.
Yeah.
Uh, there are inhaled steroids. Pretty hard to do it with topical steroids, but it can certainly happen.
Hmm.
Um, so we have to think about those things when people are referred to me. Usually it's because we're trying to figure out, do they have a pituitary tumor making too much of the adrenocorticotropic cortisol stimulating hormone, or do they have a tumor on their adrenal glands making too much? There are very rare cancers that out there that can make too much. When
Right.
those are occurring, not that your fans want to hear about this, but that's so dramatic that people do
Yeah.
not gain the weight that people think of when they think of too much cortisol. They just deteriorate. They're breaking
Yeah.
down.
Right.
Um, if it's a very subtle process, especially if it starts in childhood,
Hmm.
because of the way it works on appetite, metabolism, and our just that whole metabolic milieu, people do tend to develop what looks like obesity, right?
Okay.
In adulthood, uh, it, the more severe types of Cushing's, people tend to get really thin, but with abdominal obesity, because
Right.
it's so bad for our muscles.
Hmm.
And then it all goes into our belly. Yeah, we get diabetes, they get
Yeah.
osteoporosis. You get something called facial rounding and plethora, so a round, red, and face. It's a moon, what they call moon faces.
Oh, okay.
You get more fat around your clavicle and behind your neck. Those are kind of specific things that we can see. You get stria that are like big purple growing stretch marks, especially on your belly.
Oh.
Hair loss, acne,
Hmm.
facial hair you don't want. Those are signs of Cushing's syndrome for sure.
Yeah.
Too
Yeah.
much. Um, but just normal processes that cause excess cortisol, that's a normal thing. So when you
Hmm.
hear the quacks out there saying, "Oh my God, you're not allowed to do high intensity exercise because it increases cortisol," that's normal. So
Yeah.
forget the fact that it increases cortisol and they're trying to say that high intensity exercise is bad. That's just not true. We
Yeah.
know high intensity exercise is good for
Hmm.
people. So
Hmm.
just because you happen to increase your cortisol during that's just a normal thing. Your body's
Yeah.
supposed to make more cortisol when you're stressing your body out like that.
Yeah.
But we don't want people to be chronically stressed with high levels of cortisol, because that's not good, but it's not the cortisol's fault. Don't blame the
Yeah.
adrenal glands. We got to work on stress reduction.
Hmm.
Other things that can actually cause high cortisol levels are things like anorexia. Interestingly,
Yeah.
so people who have anorexia have just really high levels of cortisol. Well, they
That
don't
makes
look like
sense.
they have obesity and stuff like that. They're not
Yeah.
struggling with weight reduction, but that's also not a good thing It can trick people though if it gets checked, right? So that's why
Yeah.
we also have to be careful about what labs we are doing and not following what these people out there just ordering all these batteries of tests that that people are selling online. You know, don't just go check your cortisol. You really, and even most doctors are not just going to check your cortisol. It should
Yeah.
probably be done with an endocrinologist because there is a lot of nuance to that.
That makes sense. Yes, that
But
does.
that's too much cortisol. Adrenal
Yeah.
insufficiency, if your pituitary doesn't work, or more dangerously, if your adrenal glands stop working because of autoimmune disease or bleeding or injury or maybe infectious diseases, those are certainly rare. Then you don't have enough cortisol for those stress responses. And that's very dangerous. You have dramatic
Yeah.
weight loss, very dramatic fatigue. If it's the adrenal glands themselves, the pituitary is trying to crank it out, that ACTH stuff, and it actually cleaves off, and it's stimulating your melanocytes, the tanning cells in your skin, so you get a really
Yep.
good tan. So I always ask people, well, did you get really tan in the winter? Well, it might sound great, but it's not good.
Yeah. Right. No.
And they have low blood pressure, they're lightheaded. It's
Yeah.
very, very dangerous
Yeah.
condition. So that needs to be treated with steroids. But that's different than what people I'm sure hear about as adrenal fatigue, which is not even a real thing. That's just a term that all the quacks say everyone has so they can sell supplements, but that's not a real disease process. They have fatigue from something else. It's not their adrenals.
Yeah, yeah. And I think that's like one thing that you mentioned that's really important is you are supposed to have cortisol. It's not like if you don't, obviously, like you said, it's a
Yeah.
problem. I mean, just like when people freak out over blood sugar responses and insulin responding to that blood sugar spike, it's like, well, yeah, if that didn't happen, that would be a very large problem.
Absolutely.
We want this to happen.
Yeah.
Yes. And what about one other question that I got specifically that I said that I would ask you, and this might be your wheelhouse, this might be more towards an OBGYN, but women who feel like they are always struggling with weight loss, they are doing everything right in terms of consistency, resistance training, cardiovascular training, keeping mindful of their nutrition and things like that. Everything is clinically normal in terms of labs and things like that, but the scale just won't frickin' budge. What types of things with, I guess, what would you have to say if you had somebody come into your clinic with this type of an issue and they're like, what the hell is wrong with me?
Well, so in my clinic, we'd make sure that their thyroid is not dysfunctional, because while low thyroid hormone doesn't drive real obesity, if you have hypothyroidism, that's not good for your weight. Weight gain is certainly a symptom of hypothyroidism for sure. If they have any hints or signs of, like what I was just talking about, Cushing's, on the exam, we screen and evaluate for a variety of Cushing's syndrome. But more importantly, I look into if there's not any obvious clinical concern for like some underlying tumor or something, or deficiency or something else, then we talk about how complex that weight energy balance system is and how it's not their fault. That's an internalized weight bias that people have. They think it's their fault, but it's not their fault. It's the biology working against them, this environment we're in. And then we try to figure out, well, where are some of these areas that maybe we're not quite figuring out. And then we figure out, well, how severe is the disease? Do they truly have obesity? Do they have excess adipose tissue to a point that is either already causing or will cause harm? And that can range from cancers to the diabetes, heart disease, all those things. And so we screen them for complications of obesity, and that helps us all decide, well, how intense should the therapy be? Do we need to consider different medications? Which medications? Do we need to consider surgeries or some of these endoscopic procedures we just talked about on my other podcast? And then I also want to emphasize that if it's not real obesity, but they're just frustrated with their body composition, I try to get on their level, because I understand that. I was an athlete. I wanted to have a good physique and all that stuff, but I absolutely try to reinforce to everyone that it is literally what's on the inside that counts. I know that's not what everyone wants to hear. It's not probably what I would have wanted to hear, but if you're doing all those things, you're working on your nutrition, you're working on your exercise, if we can help the mental health aspect of not being so stressed out and wanting whatever that is, then we should keep doing those things. We don't have to, have a ripped abdomen necessarily. I mean, trust me, I get it. Like, Spencer will always say, "Oh, I've always had abs since I was in utero," So, some of us are able to do that, and I get
Yeah.
it. I know that it's an exception, but it is absolutely more important to focus on healthy, and that includes our mental health. There is so much mental health disease with this, and
Hmm.
I'm sure I have some too, some body dysmorphia.
Hmm.
A lot of people do, and
Yeah.
I see a lot of that too. And by the way, so one other thing that I need to mention is that when I'm doing the history with people, um, I cannot tell you how heartbreaking it is that almost every day somebody has some very significant trauma from their past that plays a role in their obesity.
Yes. Yeah.
And it is, I'm not a psychologist. It is hard to deal with, but I know it's there, and we talk about it. I want people to be open and honest with me because it helps us help them. So, that's the other thing is,
Yes.
use your resources, get with counselors. I think there are more people out there that have really, really sad trauma from their past that is somehow influencing this whole process.
Yeah. Yeah. That was something that I think it was Dr. Lane Norton had brought up in a video recently. And it didn't surprise me, but it did surprise me that
Yeah.
I'm not going to name the stat because I can't remember the exact number, but it was an overwhelming majority in this study that they did of obese women had some sort of sexual assault trauma,
Yeah, it
which
is.
is
I just can't believe it how much I see it. And
yeah,
and that's just my anecdotes, right? So yeah, the studies support it. It's really sad. I mean, that's a whole different podcast
it
with
is.
somebody
It's a
else than
whole
me.
other
It's just,
hour of a
oh
podcast.
my God, it is. But so people, if you've had stuff go on, try to, have some, I guess, insight, I suppose, and use counselors, use your doctors, use your psychologists.
Yeah.
Yeah, it's a rough world,
No,
unfortunately. So.
yeah, absolutely. Well, this has been great. I don't want to take up too much time because I feel like I could sit here and ask you questions all afternoon and you need to get to your family. But I really appreciate you taking the time to chat with me today. Can you please let everybody know where they can find you on either socials or wherever? And yeah.
Yeah, so clinically, Howland Hospital in Howland, Michigan is where we're putting together our, we've been doing a year and a half of our endocrine department and obesity diabetes comprehensive program. Social media is just at Dr. Karl Nadolsky for pretty much everything: Facebook, Instagram, a little bit of TikTok, which I suck at, and then our Docs Who Lift podcast.
Yes.
We'll talk. Maybe we'll have to have you come on that, and you can just ask
Oh,
us questions, and we can sit and talk about all these same things and any more questions you have, and
yeah.
we'll trade you.
I mean, honestly, I would love that. I would ask questions because I don't
That's
think I can
fine.
add
Hey,
anything to the
sometimes we just need people to
conversation.
ask us stuff for some of these things, and
Yeah,
yeah, reverse
that
roles.
sounds
So.
great. Awesome. Well, thank you so much, Dr. Carl. I